Well, I see that it's 12 o'clock and wanted to hand off to Evelyn Nelson, who's the principal investigator for the Heartland Telehealth Resource Center, and she'll get us started today.
Great, great to see so many folks on a line today. I know this is a very hot topic, so we're so thankful for Rochelle coming and speaking to us today about some of the updates with the Medicare physician fee schedule. Just a few reminders as we get rolling. We are videotaping today. We also ask, if you're able to, please do type in your name. But please feel free to type your questions also into the chat, and as well as feeling free to unmute yourself as we have time for questions. With that, I'll hand it over to Rochelle to really help update us. I know there's a lot of great information today.
Great, thanks, Robert. Thanks, Evelyn and Christy. So this is the time of year that I get really excited, always waiting for the final rule for for the upcoming year, this year 2022, to come out. If you didn't attend the session that we did over the summer back in July, when the proposed rule came out, I've got here, if I can switch slides, a summary of the different topics that were covered throughout the proposed rule dealing with professional fees. So we're, of course, today going to focus on the telehealth components of those, but I do want to highlight that several of these pieces, while not directly within the purview of telehealth, do affect telehealth service workflows and the performance of telehealth services, and then ultimately the billing of them. So I'll talk not only about this telehealth category, but also the evaluation and management services and some of the rules that changed with concepts of billing those services called split or shared services, which is referring to a visit where both a nurse practitioner, physician assistant, someone that would be considered a non-physician practitioner, and a physician in the same group practice see the patient on the same day. And the rules have changed significantly between May of this year and then what we're going to see going into effect January 1st of 2022. And then I'll talk a little bit too about critical care billing and how that can impact those services if they're delivered via telehealth also. So, of course, diving into the main component of the telehealth category and discussion in the final rule, every year in the Medicare physician fee schedule, Medicare discusses the list of approved telehealth services. And this happens every year, even outside of COVID, where there is a spreadsheet that's published on the CMS website that lists the CPT codes that are permitted by Medicare to be delivered in a telehealth format. And outside of the COVID public health emergency, that telehealth format is audio, visual, live, two-way, real-time communication. And so part of that analysis on what services can be added to the telehealth list in a normal environment outside of the COVID public health emergency are different categories or ways that services can arrive on that list. So those categories, the ways that services arrive on the approved list of telehealth services, are generally one of two categories. Category one are those services that typically would be comparable to a professional consultation or an office visit or office-based psychiatry or behavioral health services, or are similar to other services that are already on the telehealth list. So for example, if we were to have a new evaluation and management code created in the CPT book, that code would not be on the prior list of telehealth services because it would be a brand new code. So requesters could ask CMS to take a look at that new code, that it is similar to consultations, it's similar to office visits, it's similar to other services that are already on the telehealth list. And Medicare would review that under certain criteria to determine if that new code, that new service, meets all of those parameters to be added under this category one type of analysis. And then there are those that category 2 that Medicare looks at that are not similar to any other services that are already on the list, but nevertheless are safe, effective, proven as a telehealth service, medically reasonable and necessary, and can consider adding them on that basis. So that is the normal way that Medicare reviews these. And Medicare went through the same process for next year, for 2022. But beyond the many services that were added to the list of approved services as part of the flexibilities and part of the waivers through the COVID public health emergency, there were no additional new services added to the approved list of telehealth on a permanent basis as either a category 1 or category 2 code for the upcoming year. Now, for this year, for 2021, Medicare created a new category of telehealth services, and it was designed to take all of those new temporary telehealth services that were added as part of the public health emergency and put them in a bucket called category 3. And these were, for lack of a better term, temporary telehealth services, meaning they're allowed right now during the public health emergency and would continue to be allowed for a certain period of time when the public health emergency ends. So initially, anything that was added to this category 3 bucket would continue to be covered through the end of the calendar year when the public health emergency ends. So I mentioned last week, I think it was, I'm losing track of time, that the federal public health emergency had officially been extended, and they extend for 90-day periods. So unless it is affirmatively revoked or withdrawn, that would take us into calendar year 2022. And so under that concept, all of those codes that were added as category 3 codes would continue to be covered through at least December 31st, 2022, if they were added as category 3, even if the public health emergency ended in January or was allowed to expire. Not all of the services that we are currently allowed to provide during the public health emergency for Medicare were added as category 3. And so you really have to be careful looking at this spreadsheet on the CMS website to see if those services are formally category 3 or just otherwise temporary allowed under the public health emergency. If they were not added as a category 3 telehealth service, that means the day that the public health emergency ends at the federal level, the ability to provide and bill and be paid for those services to Medicare also goes away. So that's going to be an important distinction and a admittedly confusing one. They did do some work in the way the spreadsheet is formatted this year that I thought made it much clearer which services will go away when the public health emergency ends versus which ones will continue to be available. The other thing that Medicare did, an additional expansion as part of this final rule, is that when the public health, regardless of whether the public health emergency ends today or in January or sometime next year, they extended coverage not only through the end of the calendar year when the public health emergency ends, for those codes added on a category 3 basis, but actually all the way through December 31st, 2023, regardless of when the public health emergency ends between now and then, and knock on wood, we hope that it does. So that extended coverage gives us some additional assurances that those services were currently provided via telehealth that were not available prior to the public health emergency. Many of those will continue to be available for an extended period of time. So then the next phase of that, or the next part of the analysis, is how would we get those services from a category 3 bucket that as of right now will go away December 31st, 2023. How do we move them to a category 1 or a category 2 permanent telehealth service? One thing to keep in mind is that there is a deadline each year of February 10th to submit requests that services be added to the permanent telehealth list. And part of the reason that we don't have any services added for this upcoming year as Category 1 or Category 2 is that Medicare didn't receive any requests by the deadline that met the requirements for Category 1 or Category 2. Keep that in mind. If you are rendering any of these temporary Category 3 telehealth services, and if you want to submit a request to Medicare on Medicare's website to consider those on a permanent basis, I really encourage you, either through the collection of your own data and information or gathering resources and studies and other information, to put that together to show the efficacy of the services, how they're increasing access, benefits to patient usage, and things like that. Medicare wants to see that information, and they're not going to go out and look for it on their own necessarily. They really rely on the requesters of the information to supply that data to show why and how the temporary service would meet the criteria to be available permanently through audiovisual technology. Okay, so this is a list of some examples of services that there were requests to add these on a permanent basis, but they weren't received by the deadline. And so Medicare did not decide to add these as permanently covered telehealth services. Part of that too, in the neuro and psychological testing categories, under neuropsych evaluations in particular, Medicare commented that Medicare felt like there was not enough information for them to confirm that could be safely and effectively performed as a telehealth service on a permanent basis. So there's some discussion about the risk of inaccuracies in the neuropsychological evaluation process, because as part of that process, and Evelyn may be able to speak to this better than I can from a clinical perspective, there has to be some level of flexibility given to the patient to be in their environment and to be observed by the healthcare professional. And Medicare didn't know or have enough information to understand how that flexibility to like move around and be in their environment and be evaluated could be delivered effectively through audiovisual technology. Medicare also commented that the observer, the healthcare professional, has to maintain a level of professional scrutiny and remote observation. That the term that Medicare used was, it seems impractical, and the submissions didn't address those concerns. So what I think is important to, as a takeaway from that in the mental behavioral health arena, is that Medicare was essentially saying we don't have enough information and it's not clear enough on how that could be done effectively. So provide us with more information, or provide us with examples on the way the technology is being used to address or to mitigate some of those concerns. So if you're providers in those arenas, that may be something you look at collecting and submitting, because while Medicare declined to accept it this year, I felt like the door was open to continue the discussion and to continue to consider those with the appropriate information to convince Medicare, so to speak, that could be done effectively.
And Rochelle, we do have a question in the chat that
Sure.
was based off the Category 3 slide that you had from Dr. Mosier. To get Category 3 moved to permanent will require studies to document the effectiveness, and it's hard to analyze through claims if providers aren't billing. How do we capture the utilization of Category 3?
Okay, so great. And I think part of that comment is that it may be hard to capture the utilization, because right now during the public health emergency, where the place of service that we normally would report for a telehealth service is 02, and we could pull claims where that place of service is identified to know that it was a telehealth service, and do some studies on utilization and effectiveness and follow-up and things like that. Where during the public health emergency, to address some kind of technical payment issues and payment differences between facility and non-facility settings, we're actually reporting the place of service where that service would have been provided if it had been delivered in person face-to-face. So that could be 21 or 22 for hospital-based services, or place of service 11 for office-based services. So if you're using modifiers, like a modifier 95 was the predecessor to place of service 02, and many payers are either requiring modifier 95 for a telehealth service or allowing it as kind of an information only modifier in conjunction with the CPT code and the other place of service. That may be one way that you can pull the data in a claims-based way. Another option, and it requires a little bit more of technical assistance, is internally you could have like a dummy modifier that is appended in the billing system, but designed to not print onto the claim form. And so you append that anytime there's a telehealth service, and internally then you can do some data reporting and some analysis to pull those claims, but it doesn't affect the actual claim payment and adjudication because it doesn't get printed on the claim form or translated into the electronic claim data file. So hopefully, does that answer the question?
Thanks, Rochelle.
Absolutely, and happy to follow up if there's further questions on that. Another large area and category of services that have become available as telehealth services as part of the public health emergency are the therapy disciplines. So physical therapy, occupational therapy, and speech language pathology. Goodness, I'm stumbling over my words. SLP, ST, speech therapy services were not allowed as telehealth prior to the public health emergency. And there were a couple of reasons for that. One of the reasons is that PTs, OTs, and speech language pathologists were not among the types of professionals who were eligible under Medicare regulations to provide telehealth services. And if I remember correctly, the definition of a distant site professional is based on regulation and not on statute, which means that CMS could, through their rulemaking process, add those different distant site professionals as eligible, but have not done that. There are a number of bills that would propose to make those types of professionals permanently eligible distant site professionals, even after the public health emergency. They haven't passed yet. And so in the meantime, where outside of the COVID flexibilities, speech therapy, physical therapy, and occupational therapy providers are not eligible distant site professionals, Medicare is concerned about adding these codes as telehealth services because of the confusion that it would create. The argument for adding these as telehealth services on a permanent basis is that PTs, OTs, and speech language pathologists are not the only professionals and disciplines who use these codes. Physicians who specialize in rehabilitative medicine, for example, may use these codes. Nurse practitioners may use these codes. And by not having them on the telehealth list, it completely precludes those professionals who are on a permanent basis eligible to deliver telehealth from practicing their profession via telehealth the way many other specialties and disciplines of medicine and advanced practice are doing. So Medicare has actually been considering this issue for several years, even prior to the COVID public health emergency, and decided again that they're concerned about the confusion by adding the therapy codes to the telehealth list, that it would give the impression that PTs, OTs, and speech therapists could permanently deliver those services via telehealth, even after the public health emergency ends, when based under our current rule structure, that will not be the case, that once the public health emergency ends, currently PTs, OTs, and speech language pathologists will no longer be eligible to deliver telehealth. So as of right now, until we have legislation or rulemaking that would make those disciplines permanently eligible as distant site professionals, Medicare is declining to add those services as telehealth services on a permanent basis. So I'm going to shift gears a little bit and talk about, telehealth, the traditional telehealth under the Medicare rules outside of the public health emergency is defined as interactive, live, two-way audiovisual communication. And this definition can be modified through regulation. Interestingly, it's not part of the statute itself. The statute itself just says telecommunications technology. So it is Medicare and the Department of Health and Human Services that have defined telecommunications technology to mean live, two-way audio-visual communication. And that's the reason that we can have some flexibilities to allow different services to be rendered as audio-only services in certain circumstances. And actually, the agency would have the authority, if they wanted to open that up to any service as audio-only, but they haven't opened the door quite that broadly yet. So when the telehealth for mental health conditions has been one area where we have seen expanded coverage of audio only telehealth services. And we've seen it expanded in a couple of ways. Prior to even the COVID public health emergency, there were limited subsets of mental and behavioral health services, particularly substance use disorder treatment and mental health conditions that co-occur with substance use disorder treatment that could be delivered via telehealth, but the geographic restrictions were waived for those services, and they could also be rendered as audio only services. So that was kind of an exception even before COVID came about, through something called the Support Act, so a piece of federal legislation. And then even outside of all of the COVID flexibilities and waivers, we had another piece of legislation called the Consolidated Appropriations Act. And it took that a step further, from not only being limited to substance use disorder and mental health conditions that co-occur with substance use disorder, but actually opening the door to those same flexibilities and waivers for the diagnosis, the evaluation, and the treatment of any mental health disorder. And what that Consolidated Appropriations Act did is allow the home to be an eligible originating site, regardless of public health emergency status. So pre-COVID, after COVID, that will continue to be available. And we know right now home is an eligible originating site for all telehealth services. But what this did is make it permanently available after the public health emergency ends for this limited subset of telehealth services. Geographic restrictions are also waived on a permanent basis for telehealth services for the diagnosis, evaluation, and treatment of any mental health condition, not just those co-occurring with substance use disorder. Now, in the proposed rule, there were some nuanced compliance requirements for this kind of phase 2 of mental and behavioral telehealth that are not present for substance use disorder services or the treatment of co-occurring mental health disorders in conjunction with substance use. And those are that in the Consolidated Appropriations Act, in the statute, the act requires that prior to a telehealth service for the evaluation, the diagnosis, or the treatment of a mental health condition that does not co-occur with substance use disorder, that patient has to be seen in person, face-to-face, a non-telehealth visit within 6 months, so 6 months preceding the first telehealth service. Another component of that is that the statute says there has to be periodic in-person visits after that, periodic in-person non-telehealth services after that. So in the rulemaking, there were a couple of considerations. And the first is with that first initiating visit, the statute says that in-person visit has to be with the provider who delivers the telehealth service. And Medicare was considering, should we interpret that literally to mean the actual individual, who is delivering the first mental behavioral telehealth service, that person has to have seen the patient in the preceding 6 months, face-to-face in person. Or Medicare said, we do have billing rules that allow providers of the same specialty in the same group practice to bill and be paid as if they were the same professional. So should we extend and should we interpret it that way? So that's kind of one piece that was considered in the proposed rule. And the other piece is the periodic visit afterwards. In the proposal, Medicare proposed that happen every 6 months after the initial visit, meaning there has to be an in-person face-to-face visit every 6 months in order for the mental behavioral health service to be paid. And the caveat to that is it only applies to patients at home and patients who would be outside of a rural geographic area. In other words, if that telehealth service after the public health emergency ends would otherwise be covered just like any other telehealth service at an eligible originating site in a rural geographic area, this 6-month initiating visit and the periodic visit afterwards, those requirements and restrictions do not apply. It's only for a patient who is at home and or outside of a rural geographic area that would not otherwise be covered as a regular telehealth visit. I've got here in red, I'm glad I changed that to red to remind myself that home, we got some good clarification in the final rule on what it means to be at home. And I think we've had this Q&A come up previously on, if a patient goes to, is at a hotel or goes to the library, or I don't know, is at Starbucks for their telehealth visit. How do we account for that? Or is it literally the patient's actual private residence? And Medicare said they recognize that home can be other temporary locations. It could be, for example, a homeless shelter. It could be a hotel room. It could be other locations that the patient's temporarily going to that would act as kind of a residence or their personal location outside of a healthcare setting. So that was helpful guidance we got on what constitutes the patient's home. Also remember that fairly recently, Medicare added a new place of service code to distinguish when a telehealth service is delivered specifically to an individual who is at home. So that's going to be place of service 10 that we would use in those instances. In the final rule, after considering the public comments, Medicare decided that periodic visit, instead of being every 6 months, would be every 12 months. So that was hopefully a little bit of a helpful flexibility that was added there. Let me see, there was one. Talked about the home. There's no exception to that initial in-person visit requirement that has to happen within the previous 6 months. That's actually written into the statute. So CMS, although there were a lot of comments about that, they explained they didn't have the flexibility to make any accommodations to that. I will say though, a helpful
and Rochelle, we've got one question in the chat before we move on.
Yeah, absolutely.
Sorry to interrupt, but I didn't want us to move ahead till we got to it. The question is, would an SUD service to the home via audio only be subject to the in-person visit requirements?
No. If there is a substance use disorder diagnosis on the claim, that's covered under the previous Support Act, and the provisions for the 6-month visit and the periodic visit afterwards are limited to this new expanded mental behavioral telehealth availability through the Consolidated Appropriations Act. So these services that are subject to the 6-month and the periodic afterwards are only mental and behavioral health diagnoses provided via telehealth to a patient at home where there is no co-occurring substance use disorder. If there is substance use disorder co-occurring, then it's covered under the previous Support Act, and that 6-month visit and the periodic 12-month visit afterwards does not apply.
Thank you.
Absolutely. With the periodic visits afterwards that are every 12 months, Medicare does have an exception process that I wanted to highlight too. So if there are situations when that annual in-person visit is not needed, you may not have to have a periodic visit right at the 12-month mark. So for example, and I'm going to put this in quotes and read it because it comes right out of the Federal Register. Situations where the risks and the burdens associated with an in-person visit outweigh the benefit. That can include, but is not limited to, when the in-person visit could cause disruption to service delivery, has the potential to worsen the patient's condition. There was another example for a patient whose condition was stable, well controlled, and that the risks or the burden in coming in outweigh the benefit of just continuing via telehealth. However, when I read that, I'm kind of thinking ahead to what that means for providers and in terms of compliance, that if you do not have a visit every 12 months, be sure you're documenting in the record why that in-person visit hasn't occurred. And to the extent it is applicable to describe risks and burdens, and then the corresponding benefit, and how the risk and burdens outweigh the potential benefit of the in-person visit. If you can use that language, if it's applicable and relevant, using those key terms will be really helpful in the event there's a medical review later on to question why that in-person visit didn't occur. That exception process was not something that was raised or discussed in the proposed rule. So I took that as kind of Medicare's way to balance not only extending from 6 months to 12 months, but also giving some leniency and some room for discretion and professional judgment, although also creating a little bit of a compliance obligation to make sure that that's being documented. Okay, so kind of step 2 of these mental behavioral health services being permitted via telehealth in ways that would not otherwise be allowed once the public health emergency ends, for individuals who are at home and individuals who are outside of a rural geographic area. The ability to deliver those as audio-only services will also continue on a permanent basis when the public health emergency ends for mental or behavioral health services covered under the Consolidated Appropriations Act. So they've got that initiating visit. They have periodic visits afterwards at the 12-month mark. They can be more frequently. That was sort of the minimum, unless the exception process applies and that 12-month visit's not necessary. So the piece that they clarified in the final rule is that the availability to do those via audio only is not only the newly covered services as all mental behavioral health conditions, but that also applies to substance use disorders. So saying that another way, audio only telehealth is available for the diagnosis, evaluation, and treatment of substance use disorders to patients at home and or outside of a rural geographic area, as well as any mental behavioral health condition, whether or not co-occurring with a substance use disorder. One caveat, I should say, is that when a service is delivered as audio only instead of audio visual, we have to make sure we're documenting why we're doing audio only instead of an audio visual component. So that can mean a couple of things. The examples in the rule say that the patient is unable or unwilling or does not want to use two-way audiovisual technology or doesn't have access to that. So that's something we want to make sure gets translated into the note for an audiovisual, or for an audio only telehealth service. That could be, simply a matter of bandwidth, or Wi-Fi doesn't work to have, I don't know, a FaceTime-like telehealth service or whatever platform is being used. However, the provider has to have the capacity to join audio visual two-way real-time communication. So that's an obligation on the provider. If the patient does not have the ability, then you don't have to join as an audio visual visit. It's just that the provider would have that capability. The other thing to note is there were considerations in the proposed rule of should we limit the level of service that can be rendered as an audio only visit? Should we exclude certain services like a crisis intervention psychotherapy code, or psychotherapy codes where the psychotherapy add-on is used in conjunction with an evaluation and management visit? So after considering that proposal, Medicare did not finalize any restrictions in terms of the level of service, the crisis intervention code. If they are otherwise on the telehealth list, they can be delivered as audio only services under this exception as well, for the diagnosis, evaluation, or treatment of mental or behavioral health conditions. Okay, so I'll pause there before I move on to another topic if there are any other questions in that arena.
I'm not seeing any in the chat, but
Okay.
feel free to type them in the chat and we'll make sure we get to them.
Okay, perfect. Lots of nuances to those exceptions for sure. Another piece of this, we've been talking about the services from the distant site professional's perspective. The originating site, remember, in most cases gets to bill an originating site fee as well. The vast majority of the time that the patient is at home as an originating site, there's not an ability to bill an originating site fee unless you have a professional who's actually there on site at the patient's home with them. And that may be a possibility to bill the originating site fee. So the originating site fee gets updated every year. It's been increased every year. It started at a flat $20 fee anytime the Q3024 code is reported. And then the originating site fee for next year is set at $27.59. Okay, so that's kind of the broad category of telehealth services in the traditional context of all of those requirements of the patient being in an eligible originating site by an eligible distant site professional, what services are on the telehealth list for 2022, and the availability or the extension of some of those flexibilities, even beyond the end of the public health emergency to December 31st, 2023. I do want to talk about indirectly some rules in the physician fee schedule on how you assign different codes and how you bill for them when they're delivered a certain way, including via telehealth. There were some considerable changes in the evaluation and management service category from some longstanding rules that had been effective that I think are important to address depending on your workflow that may come into effect in terms of who and how we bill for these services when whether they're delivered in person or whether they're rendered as a telehealth service. So the first of these concepts is called a split or a shared visit. So by definition, this is an evaluation and management service that is performed split or shared between a non-physician practitioner and a physician for the same patient on the same day. So often this comes up, it may come up in a long-term care setting or in the hospital setting where the non-physician practitioner, like an APRN or physician assistant, rounds on the patient in the morning, and then the physician may round later that day for the same patient. And there were some rules in place on when and how we bill for that had been in place in the Medicare manuals for a long time that have changed significantly this year. And when certain criteria are met, that split or shared visit could be billed under the name and the number of the physician who provided part of that split or shared service. And the result is getting the full physician fee schedule rate as opposed to the discounted non-physician practitioner rate of, say, 85% of the physician fee schedule for a PA or a nurse practitioner. So this was a way to potentially collect the full physician rate when those criteria were met. So the rules for this previously had been in writing in the Medicare Internet Only Manual 104, Chapter 12. So that's the claims processing manual, and it's the chapter for physician or other healthcare professional services. So it established some rules like split or share, this concept. Christy, I want to make sure, is my audio still okay?
There was a tiny glitch for a second, but I am hearing you just fine right now.
Okay, perfect. I saw an alert that it switched my microphone. So jump in
Yep.
if for some reason the audio goes out.
Absolutely. And while we're paused, we do have a couple of
Sure,
questions in the chat. Can you speak to the audio only not being accepted for risk adjustment, HCC assignment, submission?
No, not specifically. Maybe I can get some more information on that question and do some follow-up research and information.
Sure. And that was a question from Deb Palmer. Deb, feel free to either type more in the chat or unmute and help us clarify that here. And then there was an additional question on remote therapeutic monitoring codes, if we'll be talking about those today, or if I know we are doing a deeper dive on remote monitoring on December 9th as well.
Yes, so I've got a slide here at the end where we'll talk about that, and if there are questions or specific aspects of that you want to make sure I discuss in the next session, that'd be a great chance to put them in the chat here, and I'll take those down and make sure I incorporate them into the next session. Let me just jot down this note: audio only not accepted for HCC reporting. And then if Deb has more information on kind of the specifics of that or the question, then I can definitely do some more background research and provide information after the session as well as follow up. All right, I don't know that real quick. Okay. So the concept for split or shared billing, the ability to bill those services provided at least in part by a non-physician practitioner under the name of the physician and receiving the higher rate of reimbursement, previously in the Medicare manual required that the patient be established. So under billing rules, that means the patient has seen that provider or another provider of the exact same specialty and subspecialty in the same group practice in the last 3 years. It also required that the physician perform a substantive portion of the visit. And I put that in quotes because that was really the crux of a lot of confusion and what constitutes substantive. The requirement makes sense, right? We want the physician to do more than just kind of a peek in the door, hey, how you doing, in order to support the higher rate of reimbursement. But it definitely led to a lot of confusion and lack of clarity. The problem with that is that in the manual, that is not, that's an agency guidance document. It never went through the rulemaking process. So what we're talking about right now in the Federal Register in this final rule, it went through the Administrative Procedures Act process of publishing a proposed rule, allowing the public to review it and comment on it, and then issuing final rules based on those comments. And the Medicare manuals don't do that. They should be providing clarification and guidance, but not creating new rules that haven't gone through the rulemaking process. So December of last year, we had some regulations called good guidance regulations that create this process to dispute agency guidance that never went through the rulemaking process. And the split shared rules and critical care codes from the evaluation and management section received a petition to remove those provisions from the manuals that never went through the rulemaking process. And that's what happened. So May 9th of this year, these long-standing rules that we'd had in place for years and years were just removed, and we were left without guidance on when and how to handle these services and the billing for them. So we had the proposed rule come out in July, and now the final rule that gives us guidance on when and how we can report these split or shared visits under the name of the physician to be paid at the physician rate versus the non-physician practitioner rate. So starting right here in the middle, the definition of a split or shared service under these final rules is that it is an evaluation and management service in the facility setting that's performed in part by both a physician and a non-physician practitioner who are in the same group and then in accordance with laws and regulations. So let me touch on a couple of pieces of that definition that are important. And the first of that is the facility setting. In the claims processing manual 100-04 on the CMS website, there is a chapter, it's either chapter 12 or chapter 26, I'm forgetting off the top of my head, that identifies all of the place of service codes that you would report for services like 11 or 22 or 19, and it identifies them as facility or non-facility based places of service. So this is referring to those places of services that are identified as facility places of service that would be subject to facility payment rates and not the non-facility or non-institutional payment rate under Medicare rules. Physician has the same definition as under the Social Security Act, which is an MD, a DO. It could be a chiropractor, and I believe a podiatrist as well. A couple of changes that happened from the rules that we had prior to May 9th, when these were taken out of the Medicare manual, is that now these can be provided to new or established patients. And in the facility setting, that could be an initial visit or a subsequent visit in terms of the category of the codes that you're using to report these. Another change is that while they were also only allowed in the facility setting previously, they were not allowed specifically in the skilled nursing facility or nursing facility settings. Now they are, and not just the hospital facility setting. The real change that occurred with this final rule is what constitutes a substantive portion. And man, if you thought the audio only mental behavioral telehealth services was complicated, fasten your seatbelt, because it could almost not be more complicated on how we determine this. The substantive portion is determined by which provider rendered more than 50% of the service. But Medicare recognizes that that doesn't necessarily mean face-to-face time with the patient. So the history and the exam could be face-to-face. Part of that may not be face-to-face if you're pulling some of the history from previous medical records. Medical decision-making may not always take place face-to-face with the patient. So the two providers have to document their respective times dedicated to their portion of the history and the exam and the decision-making and the counseling and the coordination of care with the patient. and how much time they spent on that. It doesn't have to be continuous on a particular day. That is true even if the level of service you are reporting is not based on time, but based on history, exam, and decision-making. So that is going to be a considerable change for the non-physician practitioners and physicians who are not used to reporting their time on every single note. If we are wanting to use the split shared billing option to bill under the doctor, they are all going to have to document their time no matter what. And then we have to decide which provider rendered more than 50%. If that's the doctor, then we are allowed to bill under the doctor's name and number and receive payment under the higher physician rate. But if the non-physician practitioner's time is 1 minute more, then we have to bill under the non-physician practitioner's name and number for that service. And the doctor doesn't get any credit for that, so to speak, other than we can still count all of their documentation together to select the code and the level of service that's going to be reported under the non-physician practitioner's name and number. So this next part I think is interesting, and I'm going to quote this because I strongly disagree with this statement, that we believe the commenters overestimate the administrative burden of tracking and attributing time. Given the advent of EMRs and the new E&M visit coding structures, this should be an easy process to figure out whose time is more. I don't personally agree with that. The medical record systems that I'm familiar with, at least, do not have an automated way to look at nurse practitioner's note, doctor's note, pull the time documentation out of that, and in an automated way decide whose time was more to automatically translate that into a rendering provider on the claim form. So I see this as a potentially a significant manual challenge to review those notes, make sure time is documented, and to decide who to bill that service under. Absent the documentation that would support billing it under the physician's name and number, or documentation that shows that that physician billed greater than 50% of the time, I'd suggest we have to defer to the non-physician practitioner's name and number because that's the lower paying rate between the two providers. Now, there is 2022 will be a transition year, because in 2023, some of the changes that we saw this year with office visit evaluation and management services will extend to other categories of E&M codes. So this year, January 1st of 2021, for office visit codes, the CPT book and Medicare moved from a system of being focused on history, exam, and decision-making, and this algorithm of a bunch of checkboxes that translates to the level of service, and instead moved to a system where your level of service is based on either medical decision-making or time. And the way we arrive at the level of decision-making changed, and there are new tables and there's a new algorithm to calculate medical decision-making, and time no longer has to constitute greater than 50% of the visit focused on counseling or coordination of care in order to be the basis of code assignment. That change happened this year, but only for 99201 through 99215. And in 2023, the plan under the CPT changes is to extend that to these other categories. So in the meantime, for 2022, Medicare said you could either use this time system of greater than 50% of the time to decide if the service qualifies to be billed under the physician's name and number. Or for 2022, in this transition year, the physician would have to provide one of the three key components: history, exam, medical decision-making, in its entirety and at the level that's necessary to support the code that's being billed, to bill under the physician's name and number. If that particular key component is the physical exam, then the physician's individual and specific documentation of the physical exam has to meet or exceed the level of the code that's being billed by the physician. Meaning the physician couldn't simply review the nurse practitioner's exam and say, I agree. They have to personally and individually repeat and separately document the exam. So it's a little bit complicated. I would say starting now in encouraging every provider in facility settings, if you're using a combination of non-physician practitioners and physicians, to document their time and figuring out what that manual process is going to be to match up when there has even been a split or shared visit, and then identifying whose time was greater to translate into the rendering provider on the claim form. Kind of start thinking about what your system capabilities and processes will be for that. Critical care, codes 99291 and 99292 is another area that changed. I'll talk about this just briefly because it's mostly focused on the hospital setting. These can be provided as telehealth services. So that's why I think it's relevant to discuss some of these key changes here. One of the proposals is that Medicare suggested bundling critical care codes 99291 and 99292 into the post-operative period for all procedures. Now Medicare decided not to do that exclusively, but when critical care is being rendered by the same provider or another provider of the same specialty in the same group practice as the provider that performed the procedure, and within the post-op period, which is either 10 days or 90 days, depending on what the procedure was, then we have to append a modifier to the critical care code. And the reason for doing that is for medical review. So that was a big red flag to me that one, we have to be careful to make sure we're adding that modifier, but the entire purpose of that modifier is to allow Medicare to identify those claims and pull those records to review them to determine if the critical care was in fact distinct and separate from the procedure. So the better, the more robust the documentation that the critical care was not a regular routine part of the post-op recovery process, the better. Critical care services previously, prior to May 9th of 2021, could not be rendered as split or shared services, meaning the first hour of critical care had to be, that time component had to be achieved by an individual, not multiple individuals of the same specialty in the same group practice, and not split or shared between a non-physician practitioner and a physician. Medicare now says, like other evaluation and management services, even that first hour of critical care could be performed as a split or shared visit, and deciding which professional bills the critical care is dependent on the same rule of the total time, critical care time for that day. And whichever provider's time is more than 50% is the provider that's going to bill not only the base 99291, but also the add-on code 99292. Okay, so I'll talk about supervision briefly as we're kind of rounding out the hour here. There was some discussion in the proposed rule about the flexibility for direct supervision during the public health emergency to be delivered via virtual presence. Outside of the public health emergency, the definition of direct supervision is that the supervising provider is in the office suite, physically in the office suite, and immediately available to render assistance if needed. That concept doesn't really translate well into telehealth services, and Medicare clarified that direct supervision can be provided for a telehealth service, and direct supervision right now during the public health emergency can be met via virtual presence, which is the ability of the provider to jump into that face-to-face visit through audiovisual technology, or jump into a telehealth session to be able to render assistance. And Medicare was considering whether to extend that flexibility of virtual presence to meet the requirements of direct supervision outside of the public health emergency. Medicare didn't reach a decision on that. So if you do have thoughts or comments, now's a good time to be formulating them to consider for submission as part of the proposed rule that will come out in July of this upcoming year. And so lastly, remote therapeutic monitoring, and I don't have a lot to add to this, so I certainly welcome any thoughts or questions that I can add to the upcoming session. We have remote physiologic monitoring currently that has sort of been an evolving service and evolving with guidelines over the last several years, designed for, it's an evaluation and management code. So it can only be reported by professionals whose scope of practice includes E&M services. And it's limited to physiologic data that is automatically collected by a device and transmitted to the healthcare professional. So that may be weight, blood pressure, pulse oximetry, temperature, and those types of measurements. New for 2022, Medicare has approved coverage for a group of codes that look and act and are structured very much the same as RPM, but they're called remote therapeutic monitoring. They fall in the medicine section of the CPT book, so they are not limited to professionals whose scope of practice includes evaluation and management services. And the original intent for these codes was to make them available to therapists and other professionals whose scope of practice does not include reporting E&M services. The other benefit of the remote...
Just to clarify, these are not level 3 services. This is a new category of services.
Say that again, these are not...
These are category 3 services.
Okay, so great question. They're actually remote patient monitoring and remote therapeutic monitoring are not telehealth services at all in terms of that definition that Medicare has under the statute, meaning there is no restriction on where the patient is located in terms of originating sites. There's no geographic restriction on these services because telehealth is designed to replace what would otherwise be an in-person service. These, by their definition, are remote. They were never in person to begin with. So there's no category 1, category 3. These are permanently covered services, even after the public health emergency. They behave much the same way in that there's initial code for the education and setup and the device, and then there's monthly therapeutic monitoring afterwards. The one piece that I'll raise that I think is a really good benefit to think about how you may be able to use this in practice is that it's not limited to physiologic data. This could be subjective input from the patient. So in the therapy context, that could be activities of daily living, that could be exercises, that could be used in the mental and behavioral health context for depression screening, cognitive assessments, functional status. There are a lot of different ways outside of physiological data that these remote therapeutic monitoring services could be used for. So when we do our deep dive, we'll jump into a lot of examples and any additional guidance we get in the upcoming month on how those services could be used and reported, but they will permanently be covered by Medicare, even outside of the public health emergency, without the restrictions that we have for other telehealth services.
Well, I want to thank you. I appreciate, as usual. I know this is very complex and also very lengthy amount of things to get through. So thank you for everything, Michelle.
Only 2,700 pages.
Yeah, as always, you could always ask questions. Please email us at htRC@kunc.edu. You can go on our website and submit a question. Know that we have our billing FAQ out there, and we'll see you in December for our next series of sessions. And we will also send out, I know this is complicated, so we'll send out the video along with the PowerPoint from today's session. Have a great day.